Alrighty, welcome back. So I'm so impressed it looks like everyone's here, even though we had a long morning, we ate lunch, there's a hurricane coming at us, but you don't care. You want to hear about white cell disorders and coag. Doesn't matter how big the hurricane is. We're going to go through some heme pass stuff today. All right. So this lecture on white cell disorders is a huge topic. It covers some reactive stuff, then all the neoplastic things like all the leukemias, myeloproliferative neoplasms, and myelodysplastic syndromes. It usually takes me about an hour and 15 minutes to get through all the stuff. And so that will take us a little bit over our 1 hour time limit, but I catch up in the coag lecture on that thing, from that time. So I just say that just in case we'll probably end up ending this lecture and taking a quick break, probably at around 2:15-ish. So we're going to look at all these things. And again, this is really a large topic. We're going to try to focus on things that are the most board relevant and then the way that the boards would ask the questions. And so as I've listed here, the boards will frequently show images of a cell that has a morphologic abnormality. So we're going to talk about some of these, how the cells can look different in Chediak Higashi syndrome, MYH9-related disorders, and some of these macrophage disorders. So again, the boards like to show a photo and then ask a question about a disease from that photo. So we're going to take that approach to kind of mimic what the boards does. And so if on your boards you saw something like this, so it's a neutrophil with these big purple granules in it, they are pointing you towards Chediak Higashi syndrome. And again, these are white cells, so we're talking about white cell abnormalities. We know that this syndrome is caused by a mutation in this CHS1 gene, and that leads to some defect in lysozyme formation, causing problems in phagocytosis and defective microtubule polymerization. So that is kind of what's going behind the scenes more in the cell. But what we see when we look under the microscope is this cell with these abnormal granules in it. And it turns out that patients with Chediak Higashi syndrome have problems in all their cells that contain granules. So melanosomes have granules, right? Melanocytic granules. So these patients with Chediak Higashi syndrome often have oculocutaneous albinism. Neurons have granules, so these patients can have neuropathy. Platelets have granules. When they're messed up, the patients can have bleeding problems. But for the most part, these patients may be asymptomatic until they get into what we call the accelerated phase, where they get some viral infection by EBV, causing them to have some kind of hemophagocytic-like syndrome. But for the boards, again, you're going to start, hopefully, with a picture of a neutrophil with these granules and pointing you towards Chediak Higashi syndrome. On the other hand, on the boards, if they show you a picture of a neutrophil that has this kind of inclusion, a Dolly body, as well as a giant platelet, they're pointing you towards these MYH9-related disorders. The most common one is Meheglин's anomaly, but there's a whole bunch of those that have, it used to be we separated these out because they had different syndromes. Now we link all these under the MYH9-related disorders because we know it's this MYH9 gene that has problems in this disease. And these patients can get large platelets, thrombocytopenia, hearing problems, cataracts, and glomerulonephritis. But again, for your boards, you're going to look for the Dolly body and the giant platelet. The next one is Alder Reilly anomaly. In this one, if you look at the cell, you see this white cell with these very dense purple granules. so purple that we can't see the nucleus so well. And we know that these patients have problems with lysosomal, they lack the lysosomal enzymes to break down mucopolysaccharidoses. So these are, if you think about the mucopolysaccharidoses, these are things like Hunter's and Hurler syndromes. These can all be related to Alder Reilly anomaly. And so I always show you the photograph and then tell you about the disease, and then I tell you a little bit about the pathogenesis of the disease, because they could easily show you the photo and they may not ask Alder Reilly anomaly, but they could say, what else does this patient have? And you could say they have a problem with mucopolysaccharidoses, or they could say associated with Hunter's and Hurler syndrome. So again, that's how you get from a photo. They often just don't ask the photo and the disease. They often ask the photo, they show you the photo, and then they ask something associated with the disease. So that's those were some of the inclusions that we can see in white cells. Now talking about some problems in the nuclei. We know the main thing here is Pelger-Huet anomaly. And again, the photograph is a neutrophil, but here the neutrophil is hypolobated, only 2 lobules held together by this little strand. And we know that we can see that very commonly when we look in peripheral blood. We can see it in myelodysplastic syndrome, where we'll just see a few neutrophils that show this hypolobation. But when you see all of the neutrophils, and they're all hypolobated, the patient often has this Pelger-Huet anomaly. This is an autosomal dominant disorder where there are these lamin B receptor mutations. So, but it tends not to have any clinical significance. So all the neutrophils look different, but clinically the patients do not appear to be majorly infected. And again, remember when they show you a picture on the board and it shows you only one cell and the cell has the abnormality, they're kind of assuming that the patient, all the cells in the patient's blood have that anomaly. So here we only see one hypolobated cell, and we're supposed to presume that all the patient's white cells show this Pelger-Huet anomaly. Okay, and then just a few problems with macrophages. They could show you Gaucher's disease or Niemann-Pick disease. And although these are both problems in the macrophages, they do look different. So on the left here, they could show you a picture of Gaucher's disease, and you may have heard that the cytoplasm looks like wrinkled tissue paper, so it has these kind of striations in it. On the other hand, in Niemann-Pick disease, they're described as having vacuolated cytoplasm. So we remember, if they showed you this, you're going to pick, with the tissue paper, you're going to pick Gaucher's disease, and that's a problem with increased glucocerebroside accumulation because it's that enzyme, the glucocerebrosidase, which is lost. And that's different from Niemann-Pick, where the problem here is this foamy cytoplasm because of sphingomyelin accumulation, because the patient has lost their enzyme of sphingomyelinase. And we talked about this earlier, just looking at some atypical lymphocytes like we see with infections, mononucleosis. We call these downy cells, although we can see them in other infections too, like HIV. And these are the cells, again, they have scalloping of their cytoplasm and outer membrane around the red blood cells, and this very dark blue look, especially at the periphery of the cytoplasm. Those are our downy cells. And again, remember that these are not the the B cells that are infected with EBV, but these are the CD8 positive cytotoxic T cells that are reacting to the infection that's elsewhere. And we did also mention large granular lymphocytes, a normal part of our peripheral blood. These cells with increased cytoplasm and scattered granules in the cytoplasm. Normally, these are less than 15% of our cells in our peripheral blood. When they're greatly elevated, we can worry about large granular lymphocytic leukemia. In that case, the cells, we have to see this accumulation